Welcome to this video on thoracic trauma, based on the Advanced Trauma Life Support, or ATLS, guidelines. This video refers to the ATLS Advanced Trauma Life Support materials. Thoracic injury is common and often life-threatening, but most patients can be treated with technical procedures without major surgery. The primary goal is early intervention to correct hypoxia, which is the most serious physiological consequence. During the primary survey, immediate threats to the airway include obstruction and tracheobronchial tree injury. Immediate breathing threats include tension pneumothorax, open pneumothorax, and massive hemothorax. This illustration shows a tension pneumothorax, where a one-way valve air leak causes a collapsed lung and a dangerous mediastinal shift. This image illustrates an open pneumothorax, where air enters the chest wall defect, sometimes called a sucking chest wound. Massive hemothorax involves the rapid accumulation of over 1,500 milliliters of blood in the pleural space, collapsing the lung. Tension pneumothorax is a clinical diagnosis. Signs include respiratory distress, hypotension, and absent breath sounds. Initial management is needle decompression at the 5th intercostal space, followed by mandatory chest tube placement. An open pneumothorax is immediately treated by closing the defect with a sterile occlusive dressing, secured on 3 sides to create a flutter valve. Definitive care requires placing a chest tube remote from the wound. This figure demonstrates securing the occlusive dressing on 3 sides to treat an open pneumothorax, allowing air to escape but not enter. Massive hemothorax is defined as more than 1,500 milliliters of blood in the chest. Management involves simultaneous blood volume restoration and chest decompression using a large chest tube. Urgent thoracotomy is indicated for persistent significant blood loss. Cardiac tamponade is heart compression by fluid. Diagnosis involves Beck's triad and a fast exam. Management is emergency thoracotomy or sternotomy. Pericardiocentesis is a temporary, last resort measure. This image illustrates how fluid accumulation compresses the heart, causing cardiac tamponade, along with an ultrasound image showing pericardial fluid. The secondary survey addresses potentially life-threatening injuries like simple pneumothorax and hemothorax, both treated with a chest tube. Other critical injuries include flail chest, causing paradoxical chest wall movement, and pulmonary contusion, the most common potentially lethal chest injury. A simple pneumothorax involves air entering the space between the visceral and parietal pleura, causing the lung to collapse. A flail chest occurs when a segment of the chest wall moves independently due to multiple rib fractures. This causes paradoxical movement during respiration, shown here on the radiograph. Additional secondary survey injuries include blunt cardiac injury, traumatic aortic disruption, traumatic diaphragmatic injury, and blunt esophageal rupture. These require a high index of suspicion for detection. Traumatic aortic disruption is a highly lethal injury, often caused by severe deceleration forces, requiring careful evaluation. Diaphragmatic rupture can lead to abdominal contents herniating into the chest, displacing the mediastinum, as shown in the illustration and radiograph. Thank you for watching this video. Remember to study, reflect, and improve.